My name is Colton Cobb, and today we'll be talking about Wilms tumor. So before we can talk about a specific type of tumor, first we should discuss what makes a tumor. Well, a tumor is just a common non-specific term for a neoplasm, or simply a growth that's not supposed to be there. Now, tumors can be filled with fluid or cystic by nature. They can be large and completely solid. There's a ton of different types of tumors, all with their own implications. The good type of tumor, not that one exists or one is good, is a benign tumor. This is a non-cancerous tumor, traditionally in a localized spot, meaning it won't spread or shouldn't spread. They usually respond very well to treatment and can be usually surgically removed. Now, sometimes these tumors are in locations where it is too dangerous to remove or not dangerous enough to justify the surgery to remove them. They can grow large enough to cause serious complications if they're in bad places such as the brain or near arteries or organs. Malignant tumors or a cancerous growth are the bad to extremely bad versions of tumors. They're often very resistant to treatment. They may spread or metastasize to other parts of the body. So if you have a cancer within your kidneys, if it metastasizes, it can spread to all over your body. They can reoccur after being removed, or if you don't successfully remove every cancerous cell, they can spread quite effectively. And cancer simply is just another word for malignant tumor. Now, that being said, there are a ton of different types of cancers, all with their own implications, all with their own types of tumors. Tumors vary greatly, and that has implications on what treatments you can and can't use, or what treatments will or will not be effective. What is a Wilms tumor? Well, another word for it is a nephroblastoma. It's a very rare kidney cancer. It only has about 500 incidences a year compared to other cancers that's next to nothing. It primarily affects children with a peak incidence age of 3 to 4 years old. Now, it can happen younger and it can happen older. As we see in the case study later in the presentation, that individual is 5 years old, so it does have a bit of a range. It's the most common kidney cancer in children, but it's still a very rare cancer. Kidney cancers in children are particularly rare. What does Wilms tumor look like? Well, primarily Wilms tumor affects one kidney. It can move to the other kidneys in later stages if they don't catch it in time. In very rare cases, it can affect both kidneys. About 4 to 5% of the occurrence rate has both kidneys without being at a later stage. And it usually grows as one solitary mass, which can make it easier to remove in the earlier stages. This is what Wilms tumor looks like. So as you can see, this is a kidney, and you could easily tell how this type of tumor might impair renal function quite drastically. And as you can see, it's one large mass. Well, what causes Wilms tumor? That's largely unknown, but there are certain things that suggest it could be genetic by nature. The things we do know is that it's thought to arise in utero, so it's thought to arise right at the beginning of life, but it doesn't have any symptoms till later on. It can also occur spontaneously. Best argument I've seen is that it could occur to genetic changes, specifically changes to chromosome 11 as well as the X chromosome, but association is not necessarily causation. If they haven't established the causational relationship between genetics and the cancer, we can't necessarily say that it is caused by it. The disease tends to run in families, which would also support the argument of it being genetic by nature. The risk of this cancer is higher in specific groups. As it is attached to the X chromosome, you can imagine why it would be higher in females, since they have 2 X chromosomes. It's higher in African Americans. Interestingly enough, there's a lower incidence rate in Asian Americans. Wilms tumor tends to run in conjunction with specific congenital disorders, which also supports the argument of it having a genetic component. One of them is aniridia, which is the absence of an iris in your eye. Another is hemihypertrophy, which is the enlargement of one side of the body. While it runs in conjunction with this congenital disorder, this can also be a symptom of Wilms tumor. Also, urinary tract abnormalities, which should come as no surprise considering it's part of the kidney. Prognosis. So, unfortunately, Wilms tumor often goes undetected. It's asymptomatic for a long time in most individuals. There's no symptoms. Tumor can become very large before the symptoms can appear, especially pain. So a child might not know what's abnormal, so they might not tell their parents, and they might not get reported for a long time. However, like most cancers, prognosis is better with an early detection. Improved diagnostic procedures have allowed for earlier detection. Long-term survival is excellent in this type of cancer with an early diagnosis. In most Wilms tumor cases, tumors are identified before they metastasize and at a very early stage. Since it's one solid mass, oftentimes it'll be found physically and then reported. For diagnostics, they do a family history, since this cancer tends to run in families. That is an obvious place to start. They'll do an individual history as well, as far as the symptomology, what's going on, what's going wrong specifically. They'll do a physical examination. They'll feel the abdomen, particularly where the kidneys are, feel for the one large mass. They'll do a blood urea nitrogen or a BUN test. Basically, this gives insight into kidney health and protein breakdown. They'll look at your creatine and your creatine clearance, as well as a complete blood count. Complete blood count, or a CBC, gives a lot of insight into different adverse health effects that could be occurring well beyond Wilms tumor. They'll do an abdominal computerized tomography, a urine analysis, and a biopsy as well, pretty standard. As most cancers, or all cancers are, they have a staging guideline. Stage 1 is the cancer is only on one kidney. It is localized to that one location and can easily be removed with single surgery without all the other more, I don't want to say invasive, but unpleasant treatment types such as chemotherapy. Stage 2 is cancer has metastasized to the tissues and structures very near to the kidney itself. Stage 3 is the cancer has metastasized beyond the area of the kidney to nearby lymph nodes and other structures within the abdomen. This is when we're starting to get a lot more dangerous with a worse prognosis. Stage 4 is the cancer has metastasized to distant structures such as lung, liver, or brain, so very bad. And then stage 5, cancer cells are found in both kidneys, so complete kidney function is dropping, as well as in distant structures such as the brain, liver, lungs. Usually surgery is all you need for stage 1 and 2. However, stage 3, stage 4, and stage 5, surgery is most likely not going to remove the problem. Potential symptoms of Wilms tumor is an asymptomatic abdominal mass. It's usually not painful, usually not even tender, and it's nothing that would concern a child traditionally, which could make it not show up till later. High blood pressure, which is fairly abnormal in a child in the first place, so that's a good telltale. Hemihypertrophy, or enlargement of one side of the body, which is a fairly obvious telltale. Hematuria, or blood in the urine. Urinary tract infections. Abdominal pain. Abdominal pain is usually a sign of a late-stage Wilms tumor. Nausea and vomiting. You can see anorexia, or unwillingness to eat in children. Bowel pattern changes, particularly constipation most of the time. Weight loss and fatigue also can show up as a symptom for Wilms tumor. Standard treatment protocol is primary treatment is surgery, a simple, partial, or radical nephrectomy. So basically, removing either part or the entirety of a single kidney. Now, once again, this is usually only effective in stage 1 and stage 2 of the cancer. The problem with stage 3, 4, especially 5, when it's on both kidneys, is you don't want to remove both kidneys. Chemotherapy and sometimes radiation therapy, especially in the later stages. Child cancers also carry certain implications that adulthood cancers don't, such as they need support groups, they need playtime. Oftentimes these children don't understand what's happening to them. They also don't understand what cancer is in any capacity, so it's very hard on both the families and the kid. Treatment's highly dependent on stage. Like I said before, stage 1 and 2, removal via surgery is an easy option. Easy is a relative term. Stage 3 and on, surgery is possible, but complete removal is very improbable. The case study we'll be looking at today is primary extrarenal Wilms tumor, a rare presentation of a common pediatric tumor. So, extrarenal Wilms tumor is a rarer version of Wilms tumor. Traditionally, it's extrarenal, meaning it's outside the kidney. And what they mean by common pediatric tumor is while Wilms tumor is rare, and while extrarenal Wilms tumor is rarer than Wilms tumor, it is the most common kidney cancer in children. This type of cancer can have various locations. Retroperitoneum, uterus, skin, and thorax are common locations. Background, it's an even rare variation of this rare childhood cancer. It more often comes out of India. Now back to the genetic argument of this cancer. India, due to the political and social structure, sometimes they have some incestual families which would support the argument that this could be a genetic cancer, but once again, without correlation is not causation. This type of Wilms cancer is often misdiagnosed for other retroperitoneal cancers, simply due to the fact that it's extrarenal or not attached to the kidney. This specific case, a 5-year-old was brought into an outpatient department. A physical examination revealed a firm, non-painful, non-mobile, non-tender intra-abdominal lump in the right lumbar region. So fairly consistent with this type of cancer. It was non-painful and non-tender, yet there was a physical lump. Probably the best way to identify this cancer. A sonographic examination of the abdomen was requested in response to this. The child had 2-month history of aching abdominal pain with no history of fever, nausea, vomiting, weight loss, or blood in the urine. So none of the other symptoms were arising. There was no significant history, like personal history as far as symptomology goes, and it was an unremarkable family history, even though it tends to run in families. The child also had fairly normal vitals. Routine laboratory parameters were followed. They did a hemogram, a blood count, liver function test, kidney function test, and serum electrolytes, all of which were unremarkable, so all the lab tests showed nothing abnormal. Investigators, this is a few direct quotes out of the case study itself. They did ultrasounds and different CT scans, which revealed a well-circumscribed heterocoic intra-abdominal mass lesion closely abutting the inferior pole of the right kidney without evident renal involvement or infiltration. While it may be complex, simply they found a mass lesion closely to the inferior pole of the right kidney, and it did not have renal involvement or infiltration. So it did not appear to be involved in renal function, which makes sense considering all the lab tests didn't show anything abnormal, and it wasn't infiltrating the kidney itself. The mass showed internal vascularity in necrotic cystic areas, so there was some necrosis, and it was cystic by nature. Contrast-enhanced CT revealed a well-defined hypodense solid cystic tumor located to the right of the kidney, closely abutting the lower pole, as the ultrasound also revealed. Notably, the tumor partially compressed the vena cava, yet at the same time there was no obvious local or vascular infiltration observed. So it seemed to be compressing the vena cava, yet the tumor didn't invade any of the vasculature or local organs or blood flow. As far as treatment goes, they did an exploratory lobotomy, and they confirmed the diagnosis of Wilms tumor. It also had favorable histology. Since the ipsilateral kidney was uninvolved and the contralateral kidney was normal, the diagnosis of extrarenal Wilms tumor was confirmed. So basically it was Wilms tumor, which is a form of kidney cancer, but it was not directly affecting the functionality of the kidneys. Outcome and follow-up. Post-op, the child was started on chemotherapy and radiotherapy, so surgery itself wasn't enough to remove it, the cancer that is. Follow-up was conducted with sonography initially at monthly intervals for 6 months, followed by 6 checkups a year for the next 2 years, and a CT of the abdomen was performed after a 6-month period. There was an excellent treatment response, as is consistent with what is traditional for the Wilms tumor, and there was no signs of residual or recurrence tumor. So what that means is there was no sign of any tumor left over to reproduce, and there was also no sign of a reoccurrence tumor. Thank you very much.